In this video, we discuss the promise of sonodynamic therapy as a cancer treatment. As always, these ideas are discussed in more depth in the book Cancer Self-Defense 101, Quick Tips to Help You Survive. All citations for studies quoted in this video can be found in the book's bibliography at cancerselfdefense101.com. This video is intended as information, not medical advice. It is not intended to treat, diagnose, or cure any disease. Any medical advice should come from an appropriately credentialed medical professional familiar with your unique circumstances. Sonodynamic therapy, SDT, is very similar to photodynamic therapy, PDT, discussed in another video. SDT uses sonosensitizers, sound-sensitive molecules to kill cancer, just as PDT uses light-sensitive molecules. SDT's mechanism of action, however, is more complicated than PDT. Sonosensitizers are able to produce light and reactive oxygen species, ROS, when activated by ultrasound, just as photosensitizers are able to do the same when activated by light. Yet in SDT, the temperature increase caused by ultrasound can also increase ROS. This cumulative increase in ROS can itself lead to cancer cell death through apoptosis. Additionally, ultrasound can produce microbubbles that can increase the permeability of the cancer cell membrane, which the hydrophobic sonosensitizer then exacerbates. This increased permeability has led to ultrasound being used to increase the uptake of many drugs. For instance, adding ultrasound to the chemotherapy drug docetaxel led to a more than doubling of its absorption in an animal trial. This technique, sometimes called acoustic targeted drug delivery, has even been tested in human trials. In one trial, 10 patients with either stage 3 or 4 inoperable pancreatic cancer received an infusion of gemcitabine, the standard of care chemo for pancreatic cancer, over the course of 30 minutes. A commercial ultrasound device was then used on the area for 31.5 minutes at 1.9 megahertz. During the ultrasound treatment, an ultrasound contrast enhancing agent Sonovue was also administered intravenously. The results were then compared to historical controls. The treatment group tolerated an increased number of gemcitabine cycles, 13.8 versus 8.3, and median survival increased 17.6 months versus 8.9. Although ultrasound used in conjunction with another treatment modality, such as chemotherapy or even potentially radiation, can create a synergistic effect, ultrasound by itself may increase tumor size. Fortunately, many of the sonosensitizers used in SDT are the same as the photosensitizers in PDT. This includes curcumin, berberine, chlorophyll, rose bengal, indocyanine green, and acridine orange. Artemisinin and its derivatives dihydroartemisinin and artesunate have also shown themselves to be promising sono and photosensitizers. Methylene blue is a very powerful sono-photosensitizer, more powerful than any of the aforementioned sono-photosensitizers, with the possible exception of rose bengal. Methylene blue, however, has an absorbance peak of 660 nanometers compared to rose bengal's absorbance peak of 562 nanometers. So the light used to activate methylene blue when it is used as a photosensitizer would penetrate more deeply than the light used to activate rose bengal. For a further discussion of this, please see our photodynamic therapy video. There are many factors that affect which treatment modality will be more effective, SDT or PDT. But it seems as if in most cases, SDT holds its own and may even be superior to PDT. Because SDT and PDT can typically use the same sensitizers and have similar mechanisms of action, they are often used in conjunction in a process called sonophotodynamic therapy, SPDT. Many animal studies point to the superiority of SPDT over either SDT or PDT with virtually no additional toxicity, the The toxicity for both SDT and PDT is already extraordinarily low. The chart above shows the effects of the control mice that received 5 ALA, a photosensitizer with 630 nanometer light, mice that received 5 ALA with light and titanium oxide without ultrasound, and mice that received 5 ALA with light and titanium oxide with ultrasound. The tumor volume of the SPDT group is a fraction of the control group. Additionally, this shows the sonosensitizer contributing an inhibitory effect even without being exposed to ultrasound. Although SDT and SPDT have far fewer human studies examining them than the hundreds examining the use of PDT, the few that exist are very positive, including 7 people with advanced esophageal and gastric cancer were treated with SPDT and concurrent low-dose chemotherapy. 2 also received local radiation. 3 of the 7 had received prior chemotherapy and were refractory. With SPDT, 3 complete responses were achieved and 3 partial responses for a total response rate of 85%. There were only minor side effects. In another trial, 12 people with advanced breast cancer were treated with SPDT and a 1/4 dose of chemotherapy. 9 of the people had bone metastases and some had metastases in the brain. 10 of the 12 had prior chemotherapy and 9 had tried at least 2 lines of chemotherapy. With SPDT, 3 patients, 25%, achieved a complete response. 6, 50%, achieved a partial response. 2, 17%, had stable disease. And 1, 8%, had progression for a disease control rate of 92%. A Phase 1 trial examining the use of SPDT in 26 prostate cancer patients found a decrease in prostate size. A case study report of 3 very advanced breast cancer patients treated with SPDT reported 2 partial responses and 1 complete response. 1 patient had metastases in her bones, lungs, liver, and abdomen. The metastases in her neck had already destroyed the cervical vertebra. She had respiratory failure, heart failure, lung infections, high fever, and no feeling in her limbs. Her heart rate was between 150 and 170 beats per minute. Upon being transferred out of the ICU of one hospital into a different hospital, she received her first treatment of SPDT with a small dose of chemotherapy. After 1 cycle of treatment, her breathing improved and feeling in her limbs returned. After the 2nd cycle, the tumor in her neck, which initially was 13 centimeters by 6 centimeters squared, shrank to 5 centimeters by 3 centimeters squared. She was also able to breathe without a respirator. After 3 cycles, she had continued symptomatic improvements and was able to move her limbs. She eventually passed due to complications from injuries she had sustained to her neck prior to SPDT treatment. The photosonosensitizer used was Sonoflora 1, a chlorophyll derivative. The light used was a red LED, 630 nanometers, the main absorbance wavelength of chlorophyll, with a 20 MW per centimeter squared power density. The ultrasound device was 1 megahertz frequency and power density of 2.0 watts per centimeter squared. Devices with these parameters are commercially available. Application of red light and ultrasound simultaneously in sonodynamic therapy. A report of 115 patients by the same group found a doubling of predicted survival in more than half of the people treated. This included patients with brain tumors. Different sonosensitizers may be able to synergize with each other. This idea is also supported by one animal trial in which doxorubicin, which is both a chemotherapy agent and sonosensitizer, was administered with ultrasound and a porphyrin-derived sonosensitizer in different combinations. The combination of both sonosensitizers with ultrasound was more effective than either with ultrasound alone. The machinery used in SDT and PDT, for that matter, is remarkably simple. Ultrasound devices are available commercially for $150 that are capable of delivering the same power and frequency of waves used in clinical trials. In fact, some commercial units have power densities of 4.6 watts per centimeter squared. For more information, please see the book Cancer Self-Defense 101, Quick Tips to Help You Survive.